other visitor, Ravi Shah, and a close collaborator of Venk, is going to be giving our HVI VMI seminar tomorrow at noon, so please do plan to attend if you can. And then tomorrow morning, we have a very special senior HVI Fellows Research talk. So Malamo and Murad are actually going to be giving their talk about what they've been working on over the past 3 years, so please do make an effort to attend. So today it's our pleasure to have Venk come and talk with us. And so Venk has had a various illustrious and rising career at this point. So he initially graduated from the Massachusetts Institute of Technology for his undergrad degree in biology and chemistry. He then went to Johns Hopkins to do his MD PhD training as an MSTP member. He then he stayed at Hopkins for both his internship and residency in internal medicine as well as in radiology, so double trained in that regard. He went to Harvard Medical School and the Brigham and Women's Hospital from there in order to train as a cardiovascular medicine fellow as well as in cardiovascular imaging. And then from there, I believe, went to University of Michigan, where he's been there and rising in the ranks to the point of being director of cardiac PET research as well as clinical associate professor in both medicine and radiology. His CV highlights 3 important areas of work that he has been focusing on in this role. First, he's been studying emerging non-invasive methods for cardiometabolic risk assessment, utilizing both PET and CT as well as serum biomarkers. He's been looking at the effects of accreditation, training, and certification and quality outcomes in cardiac imaging, has been leading the charge in that, and has been studying early effects of chest irradiation on cardiac structure and function. His publication lists over 100 peer-reviewed publications of original research in very high-impact journals. He is now 2 R01 funded as a PI or multiple PI investigator, and he sits on a number of guideline committees and is a thought leader in this space as well. So Venk, we really appreciate the time that you've taken to come here, and appreciate the insights that you'll be able to give. Thanks, Venk.
Thank you for that altogether too kind introduction, and thank you for coming on this early hour, especially after a 3-day weekend. I know how attractive an extra 30 minutes of sleep can be. These are my disclosures. I think the most important disclosure, though, is that a lot of this work is done jointly with Ravi Shah, who's sitting in the first row, and he's going to be giving a talk on that's very complementary to this one tomorrow. So I thought I'd start by just talking about what I think of when I use the term cardiometabolic disease. And, you know, there's this huge spectrum of things that fit with this concept of cardiometabolic disease. But ultimately, I think it's this layer between environmental and behavioral exposures, as well as, of course, genetics, and then the diseases that let me see if I can get the pointer to work here, excuse me. Let's see here. And then diseases of organs that we all focus on, things like the heart, but of course also kidney failure, liver disease, that the manifest end organ dysfunction. So I put the cardiometabolic disease as the intermediate stages, things like hypertension, dysglycemia, dyslipidemia, obesity, as well as a step further of subclinical imaging-based or biomarker-based diagnoses, things like albuminuria and fatty liver disease. And of course, as a cardiologist, I tend to focus the most on cardiovascular disease, but increasingly, and as I'll talk about in this today, we also think about liver disease and renal disease and cancer as driven by some of the same processes. And this is increasingly seen as important. Over the last few years, we've seen that life expectancies in the United States have either stopped growing or actually taken small steps backwards. And there are many drivers of this. Among them are the opiate epidemic, but other things include that there's been, at least in some years, increases in the rate of death from heart disease, stroke, diabetes, and kidney disease. And when you think back about why that might be, well, we can think about these data from the CDC, where we've seen over the last 20 years or so, there's been a pretty dramatic rise and spread in the rates of obesity as well as diabetes. And perhaps even more concerning is that if you rewind and you look at that 1994 map of obesity, where you had the greatest amount of obesity here in the Midwest, Michigan, Pittsburgh, these are all kind of the obesity belt, if you will. And then some 20 years later, you see that there are increased rates of cancer and CVD in some of those same regions. And then you ask the question of where we were a few years ago in terms of obesity. And of course, that raises the question of where we're going in terms of cardiovascular disease and cancer over the next 20 years hence. And when you think about obesity, though, it's, I think, not a simple problem in that we all think about the standard definitions of obesity with a BMI greater than 30. But this paper really got a lot of folks thinking in this Yudkin, I'm sure I'm slaughtering the name, paradox, but basically both of these investigators had essentially the same BMI, 22.3, but their body fat is actually pretty dramatically different, and ranging from 9% to 21%. And some of this may be differences in ethnic patterns, but I think it goes even further than this. Let's see, this is going to move. We freeze. We froze. I can't blame anyone. This is my laptop. So not all fat is the same. So not just is there differences in the amount of fat in the body fat composition, but we've increasingly learned that the locations of fat behave differently. So the visceral fat component compartment has different behavior than subcutaneous fat. And part of this ties into this concept of adipose tissue as an endocrine and paracrine organ. And adipocytes secrete a number of hormones that have both autocrine, paracrine, and endocrine function. This has been a major insight over the last few decades, where we realize that these have a role in regulating inflammation, regulating things like angiogenesis, hypertension, various things of that sort. So how good is BMI in characterizing this? So these are data that Ravi and I looked at in the MESA study. So this is a multi-ethnic cohort, about 1,500 subjects who had abdominal CT, in addition to, of course, standard body mass index. And, body mass index is, I would say, moderate. There's a correlation coefficient with the visceral adiposity of about 0.6, so about a third of the variance explained. And similar for subcutaneous. So it's not really able to separate the two. There is a correlation, but I would say it's in the moderate range. Before Ravi and I actually started working on this, so Ravi's the one who got me interested in this area, and this was one of his earlier papers, looking at the rate of metabolic syndrome and the amount of visceral fat in MESA. So we know that BMI is certainly correlated with metabolic syndrome, but what these data show is that if you divide folks by the amount of visceral fat they have, you can see that the rates of metabolic syndrome are concentrated in those people with the greatest amounts of visceral adiposity. Importantly, though, this goes beyond cardiovascular disease or metabolic syndrome. These are data from the Framingham Heart Study, which shows that using similar approaches, using CT metrics of visceral adiposity, you can identify that the patients with the lowest amounts of visceral adiposity actually also have the lowest rates of cancer and not just cardiovascular disease. But I think it goes even further than the amount of visceral adiposity that someone has. So this is work, again, that Ravi and I did together, where we looked at different fat depots in the MESA study. And so we look at pericardial fat volume on the left and liver attenuation as a marker of the amount of fat that's infiltrating into the liver, so a marker of hepatic steatosis. And what you can see is that the different colors are different endpoints here. So all-cause death, hard cardiovascular events, and then atherosclerotic cardiovascular disease more broadly defined. And it turns out that this is actually a spline, but it actually behaves very linearly. So the amount of pericardial fat you have is very correlated with a variety of cardiovascular endpoints. On the other hand, the amount of fat that one might have in the liver, at least as measured by CT, there isn't very much of a relationship with cardiovascular events once you account for the fat around the heart. So yes, all of these things are correlated, but it's possible, this is suggestive that the different visceral fat depots actually may have different effects on various end organs. And this is diving a little bit further into that data. So if you look at the pericardial fat volume and you look at a variety of markers of cardiac structure, so you look at, for example, in the upper left, you have end-diastolic mass by cardiac MR, volume index, mass to volume ratio, and then ejection fraction. So ejection fraction, there's a hint of a relationship, but very clear, strong, nonlinear relationships between pericardial fat volume and the amount of the mass and volume and the mass to volume ratio of the heart. So again, suggestive that there's, and these were not seen when you look at the liver fat relationship as once you account for the pericardial fat volume. So this suggests that there's a local effect of pericardial fat on cardiac structure and function, as well as outcomes. When you look at cardiac MR, though, there's other things that you can do. So one of the hot areas in cardiac MR has been quantification of myocardial T1 and T2 as markers of fibrosis and edema. Ravi and I were visiting Johns Hopkins to work with one of my original mentors, Joao Lima, and also one of our collaborators in Mesa. And we're sort of brainstorming and thinking, and we said, hey, you know, every cardiac MR study actually has some visualization of the liver. This is exactly how some of the work had been done in terms of liver fat on CT. And we said, hey, you know, Mesa has T1 mapping data. What if we look at the liver? Now, of course, the liver is a really complicated organ, right? Because in addition to fibrotic changes in the liver, you can also have fatty infiltration of the liver, you can have iron deposition in the liver. So these things make it a little bit more complicated, and it wasn't as simple as, hey, let's just draw some regions of interest in the liver and see what happens. So the folks at Hopkins did a few pilot scans on folks who had liver MRs for other reasons. And what they did then was they went back and looked at these MESA data, correlating it with the volunteer experiments. And what you can show is that the native T1 time in patients who have cardiovascular disease, so this is a marker of many things, including fibrosis and fat, is clearly different in patients who have cardiovascular disease than those who don't. And if you go further and you ask the question of, is this driven by extracellular volume, there's a hint that that may be the case. It depends on how thoroughly you adjust this. And of course, that can be partially when you adjust for mediators, you of course will reduce the effect. But again, it's a hint that maybe we're actually seeing fibrotic changes in healthy community-dwelling adults who have had cardiovascular disease in the liver as well. So again, tying this further, Ravi and I also had the opportunity to work with the group in the UK run by Neubauer and Ryder. And so these folks, they recruited a number of adults and adolescents, and they did very careful measurements of liver fat using, again, MR metrics, and related them to aortic pulse wave velocity. And so there's some really important points here. So first is that there is a clear relationship between the amount of fat in the liver and aortic pulse wave velocity. But another really interesting point is that in adults, the relationship becomes steeper than in adolescents. So this suggests that there's an exposure time effect here. So that as you get older, it's perhaps there's an additive effect of exposure to these metabolic derangements of time. Another thing we looked at was, how do you relate? So we talked about the relationship between the heart and the liver. It turns out that the liver steatosis, again, as measured by CT, is related with incident albuminuria. So this, again, ties into the idea that we have to start thinking about these diseases in a multi-organ format, thinking about this as a diffuse process. And when you think back and you say, okay, well, what is the nature of metabolic disease, and when should we be starting to think about it? All of the data that we had been looking at, except for that data from Neubauer and some of the work Ravi had done before we started working together, had been really in adults, starting at around middle age, around 40. But one of the formative studies in our work and where we've gone over the last few years has been this paper that came from the Cardia study. And Cardia is a cohort that started with adults around age 8 to 18 to the mid-20s, and they've been followed for about 30 years. And what Jeff Carr showed was that calcium actually forms pretty early, so they're finding calcium in folks even in their early to mid-30s, and that even in that early age range, having calcium is additive to describing to standard metrics of risk from the pooled cohort equations and such in identifying those who will have cardiovascular events. So if you're going to start thinking about metabolic risk in a broader sense, I think another important point that increasingly has been a focus of interest, particularly among the surgeons, has been tremendous interest in trying to understand whether we can quantitatively and reliably assess frailty. And so these are data that we generated out of the MGH TAVR experience, which looked at the psoas muscle volume, and the area as a metric of muscle quality. And these are all elderly folks who are undergoing TAVR, and what you can see is that the amount of psoas muscle, even after a pretty comprehensive adjustment, is clearly associated with survival. Now, these are all older folks, and eventually they all pass on, as been seen in all the TAVR registries, but they survive longer and presumably better by having better muscle quality. So when you think about this and we're saying, okay, that metabolic disease affects the liver, affects the kidney, affects the muscles, and we think about the fat distribution, well, why don't we think about this more broadly and just say, let's characterize the entire body all at once? So here we took data from the CHS, the Cardiovascular Health Study, and these subjects all had DEXA scans with pretty detailed quantification of the amount of fat and muscle across a variety of locations, so including visceral and visceral fat, limb muscle. And you can take all of these data and you can do principal components analysis. So it's a matrix factorization technique trying to find the primary axes along which these vary together. And it turns out that two axes or components really describe much of the variation in this cohort. And one is the amount of fat, and the other is the amount of lean mass that you have. It kind of makes sense that they sort out that way, but it doesn't have to have worked that way. And it turns out that there's a pretty linear relationship between the amount of lean mass you have and the hazard of death in these older adults. Whereas fat, it turns out that there's a very nonlinear relationship, and it's really only at the tail end, those people who are at the low end of this component, that end up having increased mortality. And so in this older population, this is probably a marker of frailty again, right? So we're seeing that those patients who have, those subjects who have less muscle and are just generally more frail are dying earlier. Can we go further and look more detailed and look at organ composition across the entire body? So these are data from the Framingham Heart Study, where we took about 3,000 patients who had patients, who had calcification across multiple vascular beds, the amount of fat in multiple parts of the body, liver attenuation, muscle quantity and quality. These were all entered again into a classification scheme. It's a form of unsupervised machine learning that you can do. And what you find is, again, there's three principal components that characterize most of the variation in this cohort. One is global vascular calcification. So all of these things, thoracic arterial calcification, coronary artery calcification, abdominal aortic calcification, valvular calcification, they all travel together. And then a second component, which is mostly comprised of various adiposity beds. So the amount of fat in the thorax, the amount of visceral adipose tissue, pericardial fat, and subcutaneous fat. And then a third, which is related to muscle characteristics. So interestingly, you can also take this and you can do clustering on these and identify two basic groups, one that has better characteristics than the other. And you can see that even accounting for traditional risk factors, that there's incremental, even after adjustment, this survived comprehensive adjustment, risk stratification for all-cause mortality and incident CVD. So we talked about how these things all start early, and we have to kind of think broadly about in a multi-organ format. But I think one of the critical features is that obesity starts very early in life. And so these are data that have shown that really pretty consistently across time with earlier birth cohorts in blue and later in white, we see that obesity changes actually start pretty early in the early teen years. And this was a seminal study from the late 90s showing that atherosclerotic changes can be found even in teenagers and in folks in their third decade of life. In the left side, you see the prevalence of fatty streaks. So fatty streaks are really common in folks even in their 20s and 30s, in as much as about 10 to 20% of people. And then even raised lesions, so plaques, so to speak, are present in many patients, many subjects by the time they're in their 30s. These are all autopsy data from people who died of non-cardiac conditions. Work that I did in an earlier phase of my career was looking at coronary vascular function and how it's related to outcomes. So the reason why this is connected is that when you think about what are the earliest manifestations of atherosclerosis, those patients who have fatty streaks or non-obstructive plaque, they will have abnormal vasomotor function. So these are data looking at about 2,800 people who are all undergoing cardiac PET scans. And what you see is that regardless of how abnormal traditional metrics of perfusion imaging are, so these are patients with severely abnormal scans, these are patients who would have been rated as normal. The patients who have abnormal vasomotor function, the orange, always do worse. So these are people who have diffuse atherosclerosis and or microvascular function, even if they don't have obstructive coronary artery disease. So how can we keep diving further into this? How can we get more answers? We've leaned really heavily on the Cardio study. I've already shown you a couple of results from there. So the Cardio study is a longitudinal study of about 5,000 adults. They were mostly in their 20s when the study started. Now they're in their 50s. A balance between Caucasians and African Americans, and they've been followed up roughly every 5 years or so over the last 30 years. They get blood work at every exam. There's been exercise testing at a number of exams, pretty comprehensive imaging, and lots of other kinds of survey and other types of assessments. These are data from Nori Allen's group, again looking at the Cardio study, and what they did was they characterized the trajectories of blood pressure as a function of age. So starting with the average age somewhere around 25 in Cardio, you can see some people stay with stable low blood pressures. Others have blood pressures that are stable but a bit higher, and then you have a few groups where their blood pressures are rising. And across these, what you see is that the likelihood of developing coronary artery calcification in their later exams when they're getting to middle age is clearly related to the trajectory that they're on, right? So even knowing that their blood pressure is normal, they're all normal to start out with, or very nearly normal, and don't really become abnormal until we're already seeing calcium in many of these groups. So that's important. We're just seeing the change that is going in the wrong direction is an important feature in early adulthood. Delving a little bit further into the blood pressure phenotypes in this cohort, so these subjects also underwent exercise testing. And so, of course, when you exercise, your resting blood pressure here in this kind of peachy pink color rises into this distribution that you see in the cyan blue. And what happens is that those people whose blood pressure rises more at submaximal exercise actually have higher rates of cardiovascular disease, even in young adulthood and early midlife. So these, again, as I said, they're only now reaching their 50s, and we're seeing more cardiovascular disease unmasked by having a treadmill test in their 20s and seeing what happens at submaximal exercise in terms of their blood pressure. Overall fitness is associated with less cardiovascular disease in this cohort as well, but actually the gradient is probably stronger by understanding what happens with the vascular function in those people at that age point. So yes, knowing how far you can run is very important, but how your body responds to that exercise in terms of what happens to your blood pressure is also incredibly important in understanding this. But every minute of increased treadmill time associated with 15% lower risk of death and 12% lower risk of cardiovascular disease. But importantly, overall fitness was not associated with coronary artery calcification in this cohort, but how your blood pressure responded to exercise was. You can take the same concept of how does your blood pressure change over early life or early adulthood and ask how is your metabolic health changing. So you can take the ATP3 metabolic syndrome components and you ask, can we group these 4,000 people who've been at most of these exams in cardia and say, how do they change? Do some people stay the same? Do some people get worse? And in fact, they do. There are about 6 different overall categorical groups that you can create. Some people are low and they stay low. Some people start out with kind of a little bit higher rate of metabolic syndrome components, but they still stay roughly stable. But then there are other groups that rise. So overall, you have about 6 different groups. Some are stable, some are rising. And the interesting thing here is that all of these are correlated with things like the cardiac structure, function, and outcomes. So if early adulthood is already showing you that we can find people who are developing calcium, who are having events, who are having adverse outcomes from both a cardiovascular and metabolic perspective, should we be working on treating these people? Should we be thinking about how to modify that risk? So this was work that we did, that Ravi and I did when the newer pooled cohort equations came out. And I remember Ravi and I we got this data and we're like, we got to understand this right away. So we went to work and we looked at the NHANES data. Literally, we're texting back and forth every 30 minutes, trying to understand how this changes risk stratification. And what you're looking at here is age, looking at data from NHANES, and we're asking what percentage of people are indicated for statins based on both ATP3 and the newer pooled cohort equations in the cyan color, the newer equations only in the purple, and then just ATP3, which is just a tiny sliver in this sort of tan color. And what you can see is that overall, as you get into your 50s and 60s, the majority of adults actually are indicated for statins. On the other hand, at the lower end of the age spectrum, almost nobody is. And that's really not changed. That lower end of the age spectrum really hasn't changed between earlier guidelines and where we are today. But we already know that we can find calcification in these earlier folks. Can calcification add to pooled cohort equation-based risk stratification? This has been looked at by several groups in multiple cohorts. This is work that we did in the Jackson Heart study, so an entirely African-American cohort. And what it shows is, again, that if you look at people who are statin eligible, those who have calcium versus those who do not, clear difference in atherosclerotic cardiovascular disease events, whereas those who are not statin eligible, who have low risk based on the pooled cohort equations, there's not really much additive value to calcification. So can calcium get us out of this box and identify those people who are young who we need to think about treatment early? So these are the data that are not yet published. So one of my colleagues at Michigan, Jeremy Sussman, pulled out data from MESA, and he asked the question of what's the probability of having calcium as a function of age in MESA? And so, MESA, the youngest folks in MESA are 45, and the oldest were in their 70s. And what you see is that in early midlife, the likelihood of calcium is actually pretty low. 80% of people don't have any coronary calcification. So the ability to identify the highest risk people is somewhat limited because of that. And yet, treatment early may actually have benefits. So this is a really beautiful plot that Brian Ferentz did. So Brian was interested in assessing whether LDL is causative for atherosclerosis. Believe it or not, there are lots of folks who take issue with that concept. And what Brian asked was, okay, we've all seen a plot looking at the amount of LDL lowering in the cholesterol treatment trialist consortium meta-analyses and the rate of cardiovascular disease events. And he plotted that in this red color. So these are all various randomized trials of statins, high versus low intensity, versus any statin versus placebo. And they generally fall along a line where you lower cholesterol more, you lower LDL cholesterol more, there's a greater reduction in CHD events. And then he asked the question of what happens if you look at large cohort studies. And in large cohort studies, the effect size is actually a little bit larger. And possibly that's because there's confounding. The assignment of statins is not random in cohort studies. And so that has been the standard explanation for that. Although there's another issue, which is that the lower the lower the LDL you have in a cohort study, you've had that your entire life as opposed to the 1, 2, 3, 4 years of a statin trial. And then he did something really innovative. He took Mendelian randomization data, and he plotted that in the third group in blue. And that has the strongest effect size of all of them. So here, this is looking at the genetically determined aspect of LDL cholesterol as opposed to the environmentally determined aspect, right? And so if you have a genetically determined lower LDL on the right, you have a markedly lower rate of cardiovascular events. And why is that? Because that has been affecting you your entire life from birth, right? So it's a really critical concept that the idea of changing risk across your lifetime it can have a bigger impact than just targeting those folks who are older. So the concept of lifetime risk, the concept of age as a modifiable risk factor, is that if age is our strongest risk factor, and so these are data from Framingham risk factors and CRP in, I think this was the Women's Health Study, showing that age basically is the strongest component, but this is consistent feature across all cardiovascular cohorts that sample across more than a trivial age range. Why not start treating modifiable risk factors earlier to reduce their impact? And we've been talking about this for a long time, and then a beautiful study just came out in European Heart Journal just a few weeks ago, which did a modeling exercise, and it asked the question of, if you treat younger people versus older people with the same CVD risk. So across this axis, we have categories of baseline CVD risk, and across this axis, we're looking at age categories. And what you can see is that the younger people in any category of CVD risk actually have the greater gain in life expectancy from treatment of CVD risk. And here they're talking about treatment comprehensively: cholesterol lowering, blood pressure, aspirin, and smoking cessation across that cohort. Of course, the critical feature is, though, that most younger people actually in traditional risk assessment equations end up in the lower categories because age is a dominant feature. So as polygenic risk, we talked about risk stratified, determined by genetic determination of risk of raised LDL. So is polygenic risk the answer? There's been a lot of news lately. Here's data, for example, looking at polygenic risk of obesity and BMI, which is one of the most strongly inherited phenotypes. And this group from MGH showed that the polygenic risk score can separate out body mass index across deciles, and in fact that those folks who are in the highest polygenic risk score decile actually have an increased rate of obesity over about 25 years of follow-up, looking again at the Cardia study and the Framingham cohort. And this is already very rapidly making its way out to our patients. There's a ton of marketing coming at them. I can't tell you how many times I heard Warren Buffett's radio ad around the holidays saying, take care of the one body you get in your life, you should get DNA testing. So this is a one advertisement that says, discover how your genes may affect your health with comprehensive reports. But one of the biggest companies in this space is 23andMe, which is now marketing a test that will give you a likelihood of developing diabetes down to a specific number. So in this case, this individual has a 30% likelihood based on their genetics, age, and ethnicity. So let's ask a question. So, we had access to data for the Cardia study. And, all of the genetic data sets are a little bit hard to come by. But if you ask the question about BMI, which is incredibly heritable, how well does polygenic risk do? So these are really fresh data. These are not peer-reviewed. They're not published. They're not even tweeted yet. What you find is that the predicted body mass index actually doesn't vary anywhere near the actual observed body mass index in this cohort. And the reason for that is that genetic polygenic risk scores right now for body mass index, again, one of the most heritable phenotypes out there, only count for 9% of the variation in BMI. The rest of it is either other forms of genetics, inherited behavior, and then acquired behavioral and environmental exposures, right? So, and this is a Bland-Altman plot, and you can see it doesn't look at all like what you would want it to look like. So GWAS still has a lot of issues. So first of all, the sampling of minorities is a big problem. In 2009, 96% was European ancestry. We're doing a little bit better today, but almost all of the growth in genomes from non-European populations has been from Asian populations. Very, very little is in African Americans and other groups. ultimately, though, I think that from a practical perspective, what we really need to do is to move towards risk markers that are more proximate to outcomes. And by that I mean, so DNA, of course, is our master plan, but then which is then transcribed into RNA. We see a variety of important and interesting RNAs that we can look at, mRNAs, microRNAs, link RNAs, and of course, increasingly, we can look at proteins in a high throughput fashion, and these are enzymes and hormones, receptors. Subclinical phenotypes is where we've put a lot of energy in the past in terms of morphology and function, increasingly now looking at metabolism with circulating metabolites in high throughput fashion. And then we're, of course, trying to find and prevent clinical syndromes of CAD, diabetes, and heart failure. But ultimately, the important point is that everything after DNA is influenced by environment and behavior. And as such, it integrates the effects of environment and behavior, and therefore may be more powerful actually as a practical clinical use, but also in understanding the real-world mechanisms of disease. So that's why I think proximate markers are strong. So we really effectively, what we need is a coronary artery calcium score for metabolic disease, right? That we can find early, and that may actually be manifesting earlier in this chain of events before the 25 and 30-year-olds develop calcifications. So these are data from young Finns. There have been similar data looked at in Framingham as well by Tommy Wang and colleagues. And so this is 7,100 young Finns who were in their 30s, and they did NMR-based metabolomics. And what they show actually is that amino acid levels that can be measured this way and in other ways as well are associated with insulin resistance even in these young adults. I mentioned that we can look at RNAs now in a high throughput fashion. This has become increasingly interesting because we've recognized that not only are mRNAs the message that carries the template for proteins, but also that they have an important regulatory role, and that circulating microRNAs and extracellular RNAs can even serve as a signaling role between different cell types and organs. And this has been worked on in terms of by multiple groups looking at signaling between, for example, the liver and inflammation and LDL, and looking, for example, identifying an important role for miR-122. Interestingly, we did some work together, looking at the Framingham Heart Study and then replicating in a cohort of 90 obese children from the Boston Children's Hospital, and circulating RNAs, including miR-122 especially, are related to insulin resistance in both healthy community-dwelling adults and young children who are overweight or who are obese, excuse me. So fundamentally, the question is, can we identify patterns in early adulthood which separate those destined to worsen metabolically as they age from those who will age in a healthy manner? So we proposed this to the NHLBI, and we said, hey, we're going to go ahead and quantify metabolite profiles in the Cardia study and hope that we can identify those who are on a worsening metabolic trajectory, those trajectories I showed you earlier, versus those who are on a stable pattern in early life. And then ask the question of, are these related to cardiovascular phenotypes? And then, are there relationships between these and these microRNAs that are important signaling molecules related to insulin resistance? And so these data we're just starting to get. We've now done about half our metabolic profiling, and the extracellular RNA assessments are actively being done. And I can tell you we're already, I'm not going to share today yet, but they're already showing clear relationships with both cardiovascular outcomes and metabolic disease outcomes. And so this will be, as we flesh that out more, I think we'll have a lot of interesting insights there. So this is a nested case control trial study within Cardia. We were only able to get blood from year 7 exam. We do metabolomics in about 2,400 folks, polar, positive and negatively charged lipids, bile acids. The extracellular RNA is actually, there's detailed characterization in about 300, and then further characterization in the remainder of the cohort. And we integrate these with a variety of quantitative methods, and really this has required a multidisciplinary team that includes myself at University of Michigan, Ravi at MGH, metabolite profiling at Broad. I missed UMass on there for the with Jane Friedman for the extracellular RNAs, analytics at a variety of locations. This is really, truly a comprehensive and multidisciplinary program. We thought, as we worked through this idea, we said, though, one can be young despite a chronological age, as I increasingly think as I've gotten older and as my parents have aged. I hear that more and more. And working with Dr. Ann Newman here, we looked at data from Health ABC, which is the Health Aging and Body Composition Study. So 3,000 older adults, again, community-dwelling adults, black and white. They were followed for more than 10 years. And Dr. Newman developed a healthy aging index, which looks across a variety of organs. So look at blood pressure as a marker of cardiovascular health, vital capacity in terms of pulmonary health, creatinine for renal, mini-mental status, and then, of course, glucose for the metabolic component. And you can look at the population. There's actually a distribution of healthy aging index across about 300 African-American men who had previously been assessed for metabolites. And we asked the question of, do these differ? Do the metabolites differ in folks that have healthy aging or not? And if you look at those people who are at the extreme healthy aging versus extremely poor healthy aging, you have very clearly different metabolic patterns, even in just 300 people that emerged. And so our goal now is to expand this, and we've been funded to look at this now in a much larger subgroup within Health ABC. And of course, a very important part of this is to think about biology at multiple levels. I showed you data about organ and whole body imaging, large-scale metabolomics and proteomics, signaling, molecules and genetic risk, environmental and lifestyle risk. Putting these together is hard. It requires, I think, different ways of thinking than has traditionally been used in a lot of epidemiologic studies. And one of the key things that we have leaned on a lot have been matrix factorization methods. So these are things like principal components. People use the term machine learning a lot. I'm not always a huge fan of that label, but I think the concept of penalized regressions and classification metrics is increasingly important, and we can use those concepts in important ways. And then, of course, integrating all of this with our prior knowledge of how metabolic pathways and signaling pathways work hopefully leads us to biologic insights and eventually clinically actionable data. And Ravi will talk more about the details about a lot of these things tomorrow. But when we're analyzing this data, I think it's also important for us to think about what our question is and whether it's mechanism or prediction. I think there's been a lot of debate in the literature about the importance of p-values. You guys may have seen that the statisticians are kind of at a miniature war amongst themselves about whether to keep p-values or to throw them away or to think about other ways. I'm not going to take a stance on that battle just yet, but I do think that if someone is looking for prediction, it's not just that you want to have a p-value of less than 0.05. If you want to make medically useful predictions, we need to find things of large effect sizes, which is fundamentally hard. And I think this is a challenge and important when we think about that the BMI PRS explaining 9% of variation, that is not a very large effect size. So the idea that things will change our predictive ability, it has to come from bigger effect sizes. But we can learn a lot about mechanism from things that have small effect sizes. We can learn a lot about mechanism from things that have small effect sizes. When we think about prediction, I think we always have to add to commonly available risk markers. So when we're talking about cardiovascular disease, it wouldn't be reasonable to not count things like smoking and blood pressure and lipids and age and sex and things of that sort. But if you're interested in understanding mechanism, you can take a fundamentally different approach. The genetics literature frequently does not adjust for all of these things because those are influenced by genetics as well. And once you adjust for the mediators, then you've taken away the mode by which these things act. So fundamentally different way of how we think about these things that changes our language for communication and for how we compare the results. And I think this is a struggle in our literature right now. And it leads to a challenge where for prediction, we can often turn around and start using these things very quickly, as happened with the pooled cohort equations. Published just a few years ago, now standard of care. But when we're asking mechanistic questions, often takes years, decades, even longer sometimes. But ultimately, right now, the biggest challenge, I think, is that in terms of what we do with this information, right now, all we have really are standard lifestyle recommendations. And I think we need a lot more data before we go further than that. So the core currently of AHA's message in lifestyle modification is Life Simple 7, eat better, lose weight, get active, quit smoking, manage your blood pressure, control your cholesterol, and reduce your blood sugar. All makes sense. And there's even a calculator. Patients can go to that link with that QR code and put in their information, and it gives them a recommendation. Does this work? We actually have no randomized data, really high quality randomized data on it, but there's plenty of observational data, of course, plenty confounding there. But given these are lifestyle characteristics that are covering comprehensively both diet and exercise and blood pressure and everything else you could ask, in a sense that is all the confounding package together. These are data again from the Jackson Heart Study. There have been similar studies looking, similar work in other cohorts as well, looking at incident heart failure, and those people who follow Life Simple 7 the most have the lowest rates of heart failure, and importantly, they actually also have better cardiac geometry and less remodeling and better strain parameters as well across their myocardium. And these features are generally consistent across age, sex, and whether people are obese or not. So ultimately, I think obesity and cardiometabolic diseases, it's a large and growing problem. I think it's important to intervene in early adulthood when adverse patterns are developing, and many early phenotypes are actually manifest already. Early life is an excellent opportunity to study the early stages of disease for mechanism and possibly improve diagnostics, although again, we need to find things with large effect sizes like calcium score to say that we're going to change the way we diagnose and manage patients. For the foreseeable future, I believe phenotypes will have greater impact in this arena than genotypes, but I could be wrong. Standard universal recommendations like Life Simple 7 are a great start, but it's really unclear how best to focus these interventions and counseling, coaching, and whether we need to go further than that on those young adults who have the greatest need or benefit. And we're very hopeful that we will be able to identify metabolic signatures that may have that role. But as I said, finding things with large effect sizes is not always easy. On that note, I have to acknowledge a few folks, including especially Ravi, who's sitting in the front row there. We've worked with a number of really important colleagues and collaborators on a lot of the data I've shown. Clary Klisch at the Broad Institute is really the force behind the metabolomics work on these thousands of patients. We've worked with Jane Friedman at UMass for the RNA work. And of course, all of the work on aging and gerontology has been with Dr. Newman sitting in the fourth row back here. And then other sorts of work that I haven't shown you today, I've had a number of other colleagues who I should mention. And then I have to acknowledge this has all required a tremendous amount of sustained support from a variety of sources that are important to acknowledge as well. Thanks.
I think we have time for a few questions.
Great presentation, Frank. I'm going to start from the end. How far are we from being able to start early intervention trials? And given that this is early intervention and the outcomes are going to be years down the line, are they feasible? I mean, How do we measure that your early intervention, let's say lipid-lowering agents in the 20s, is it feasible, money-wise, time-wise, et cetera?
Right. I think a couple of things. I think that the likelihood of feasibility using traditional mode of large randomized trial with a hard outcome endpoint it's not going to be feasible, except in extremely high-risk subgroups, FH-type things, which could we identify an FH equivalent subgroup for metabolic disease that maybe we start metformin on possibly, right? But I think that's a stretch. I think surrogate endpoints are definitely your friend here. And then the other piece is, what are our interventions? If you're asking about atherosclerosis, statins are certainly attractive, but I think we have to think more broadly than just statins, especially if you're treating early in life. I didn't talk a lot about it, but there are some, not not trivial, but not large, important negative metabolic consequences of statin therapy as well. So I think we have to think of what are important. We know that lifestyle modification is hard, especially sustained lifestyle modification is hard. So my thought is the most rewarding areas will be to see whether we can identify those subgroups target them for more sustained, for interventions to improve their adherence to lifestyle therapies. Can we get folks to lose weight? Can we get folks to ambulate more? Can we get folks to control their blood pressure? These are things that I think we don't need to prove hard outcomes, but yet we know we're not doing a very good job, especially in young adults, of controlling those risk factors.
Great talk, Wenk. I was just listening to you and thinking that I've never heard you present these data, although that you speak so many times, you should interact with a different mind. Congratulations on the breadth of what you've done. So now that there are so many other cohort data sets than Framingham, have you seen any difference, any ethnic variation in these relationships? For example, if you look at effect size, different risk factors have different effect size in predicting outcome in different ways. Because there are these notions that South Asians, for example, behave very differently. And these standard definitions of blood pressure, BMI, even what's optimal LDL cholesterol should meet things. And so does your data give us any hints or indications?
So great question, and I'll pay you out later for that plan. But yes, this is a really important question, and so much data has come from Caucasians, but increasingly now we have cohorts, as you point out, that are multi-ethnic. Almost all of our data, one of the strengths is that it has been almost equally African American and Caucasian, and but as you point out, the group that probably has the biggest difference in how they respond metabolically to visceral adiposity, even small amounts, are Asians, where the response to visceral adiposity at much lower levels to develop diabetes and metabolic syndrome. There are some differences in Hispanics as well. I think this is an area where we're getting better. We're moving past the Caucasian-only Framingham, but the number of cohorts that really have in-depth characterization of Asians and even Latinos is relatively small. So all of our metabolic profiling work is in Caucasians plus African Americans. We don't have Latinos or Asians in them, and that is a weakness. And I think that's an area that we would like to look further. But along those lines, we have a project that's currently under review looking at Southwest American Indians who also have kind of an extreme metabolic phenotype with markedly high rates of obesity and diabetes, which probably didn't exist in pre-Columbian era, where they were much more physically active, and there were changes in diet and whatnot. And so we're hoping to use that as a prototype to look at some of these ethnic differences. And again, one of the important features there is that that's a cohort that's been very well characterized, and it's built on work that our colleagues there have done out of NIDDK in Phoenix for several decades. So I think there's now increasing interest, for example, in South Asians. The Masala cohort, which behaves as a kind of fifth group within MESA, is now, I think, over a decade old, and as that data matures, we'll get more insights there. But we're hopeful that, assuming NIDDK funds us, that we'll get some insights that may be mechanistically similar by looking at Southwest American Indian cohorts as well.
I really enjoyed that. Thank you very much. I was wondering if there's any data for us to understand better if there is adaptation in birth cohorts over time. It seems to me that you're looking at cohorts that have had environmental exposures that have varied, and I think there's some evidence that the current obesity epidemic in the U.S., even though it's getting worse and worse, that the consequences may not be as severe as what was initially predicted, and could that be an adaptation, perhaps epigenetic?
Incredibly insightful question. This is, to put it in simpler terms, I think for myself, our genetics haven't changed for millennia. We haven't had meaningful evolution. Obesity is increasing, maybe stabilizing a bit, but cardiovascular disease is actually generally stabilizing and improving. And so how do you square the circle? And I would say that there is some adaptation, if you will, in that we have done a really great job in managing the consequences of cardiovascular disease. And I think we do a better job of treating folks when they are in their 50s and 60s and meet criteria for hypertension and dyslipidemia and preventing people from going on to MI. But whether there's an epigenetic basis to that, whether there's some innate mechanisms that have adapted, that is a really cool concept. And to be honest with you, I haven't given it enough thought. Yeah. But I think this concept of looking across birth cohorts, folks who were 20 years old, but that their data comes from, but were born in 1910 versus who are 20 years old today, and how they differ, those are really cool ideas. Assembling that data is really hard, but I think very insightful. I just don't have an answer.
I think we have one more question in the back.
Great, thank you. I was wondering if you could talk a little bit, I actually work closely with Jeff Carr, and so I was wondering if you could talk a little bit about the potential utility of fat or muscle quality as opposed to just volume when we're looking at some of these subclinical measures. I know it's sort of the way the field is going, but I wondered what your input was.
Yeah, I think, I didn't show all the papers we've published and others have published, but Jeff and others have published tons of work looking at various muscle groups, the attenuation as a metric of the amount of fat that's infiltrating the organs, the amount of fat between muscle bundles, are all related to a number of cardiovascular and metabolic phenotypes. The question is, how much do they change our risk stratification for clinical use, if I'm understanding you correctly? And I think they probably do a bit. Right now, the tools are fairly time-consuming to do the segmentation of these things. That will change. I think when people talk about the revolutions of machine learning, I think there's tons of hype in most of that. But there will be advancements in the tools for getting quantitative metrics that are useful clinically. How much they will change our clinical management, I think they're part of the story, but I don't think any of them have effect sizes comparable to calcium score. And that's the fundamental issue, right? Can you get something that will be strong enough where we say, where we are comfortable in many cases saying to a patient, despite your high atherosclerotic risk factor profile, your calcium score is 0, you're age 65, you don't want to take a statin, that's okay. We'll keep a close eye on you. Having the same level of comfort, being able to say to your patient who has a BMI of 32 at an early age and say, you know what, you should lose weight, but you're not the person that I'm necessarily going to push really hard to and focus my resources on weight loss and other things that maybe there are other groups that need much more intensive attention. And along these lines, there was recently published a study looking at early bariatric surgery in late adolescence versus in adulthood. And overall, they didn't find big differences in outcomes from a metabolic perspective. Some lower rates of hypertension or greater rates of hypertension regression. But one might ask the question of, can you identify the highest risk folks and say, hey, you are somebody who we're going to set a timeline for you to to do lifestyle metrics. And if you're not making progress in that time, then we'll have more serious conversations about more aggressive things, versus others where you can take a little bit more of a passive approach. Thank you.